Today's lecture will be on relining and rebasing the removable partial denture. The process of relining a removable partial denture is used when you wish to resurface the tissue side of the denture with new acrylic resin material. The goal here is to produce an accurate adaptation of the acrylic material to the denture-bearing area to relieve stresses on our abutment teeth. The impression is a procedure that is key to the success of the reline, and we use two techniques. One, the closed mouth technique, is used for the Kennedy Class 3 and 4, or the totally tooth-supported removable partial dentures. The open mouth technique is used for the Kennedy Class 1 and 2 removable partial dentures when we have an extension base on the end of the partial denture.
Rebase, by definition in the glossary of prosthodontic terms, is the laboratory process of replacing the entire denture base material on an existing prosthesis, be it an RPD or a CD. When you're doing a rebase procedure, you can also replace all of the teeth, provided that you have taken a jaw registration record and can mount your case on an articulator. This is often a good idea if the teeth are all worn, or you're trying to reestablish good occlusion in the posterior area and the teeth do not contact well in the posterior area. Look at all the costs and advantages of making the entire prosthesis over again before you choose rebasing as your procedure of choice. Here is an analysis of the cost involved in doing a rebase procedure and replacing the anterior and posterior teeth on the RPD. The slide shows the cost of the teeth in that first line, the tooth setup charge, and the processing fees for the repair are also annotated. The only additional cost that is involved in totally replacing the RPD is the cost of purchasing the framework. A framework is usually priced with two standard clasps, so the cost varies with the complexity of the framework. The more clasp you have, the more expensive the framework. Every facing and every tube tooth adds additional charges to your framework. So what are you going to have to charge the patient for this procedure versus the charge that would be placed on a brand new prosthesis? All this has to be considered. There are two impression techniques utilized in the rebase and reline procedures. One is the open mouth technique, and the second one is the closed mouth technique. Pay special attention to this section because it is very often part of the board examination. If you have a tooth-supported removable partial denture, the Class 3 or the Class 4, the support is achieved by positive rest seats on the abutment teeth at each end of the edentulous area. The denture base is completely supported when the patient bites down. It is not necessary to reline a tooth-supported removable partial denture if the ridge resorbs unless a few conditions are present. If you decide to reline the tooth-supported partial, you can ask the patient to bite down when taking the impression without any danger that the base will be displaced during the impression technique. The indications for a tooth-supported removable partial denture to have a reline under the base area are these. First of all, an unhygienic situation. Sometimes, especially on the mandibular, if there's a small space under that denture base, then food will get up and under it and trapped in that area and cause discomfort for the patient. The second one would be an unsightly condition, and this is most common on the maxillary arch when a space develops under the denture base and you kind of see a black hole, especially when the patient has a high smile line. This again, go ahead and reline it and get rid of that area. The third one is patient discomfort associated with the lack of contact between the denture base and the tissue. Some people find that that is an uncomfortable situation. A mouth breather, when they breathe in and out, that air getting under that little space is sometimes uncomfortable for the patient. So if they complain about a discomfort, go ahead and reline it. The last one is an anterior loss of support, which may lead the prosthesis to have movement, even though it's still tooth supported on each side of that edentulous area. If there's movement because of this, then go ahead and reline the area. The tooth-supported removable partial denture, as we have already said, cannot be depressed beyond its seated position because of the abutment teeth rest on each side of the edentulous area. So therefore, we can use a closed mouth position when taking a reline or a rebase impression. The other reason is because it cannot rotate around a fulcrum. The closed mouth technique is indicated in this type of situation. There's a clasp assembly at each end of that edentulous area, keeping it from rotating around any type of fulcrum line. One thing you do need to do is weigh the advantages and disadvantages of a laboratory reline procedure as compared to a chairside reline procedure. Here at U of L, we do not do the chairside reline procedure very often, maybe once in a while. The quality of the material is not nearly as good as having a heat-processed laboratory reline.
Before you begin, it's absolutely necessary that you determine the need for a reline or a rebase for the extension base RPD. The classic test is to determine the rotation of the prosthesis in the mouth. This is accomplished by placing pressure on the extension base at the most posterior position. You look then at the indirect retainers and the major connector, and if it is lifting away from the teeth or the rest seats, then it may be indicated for a reline. Our text recommends that if the framework lifts more than 2 millimeters, it is indicated for a reline. I think this measurement is a clinical judgment for you because there are differences in the length of the space between the fulcrum line and the most posterior point on the extension base. Torque forces applied to the abutment teeth will vary depending on these length measurements. Another option is to apply a thin layer of alginate, note the thin layer, to the prosthesis and place it in the mouth to obtain an impression. It's important that the prosthesis be held in its terminal position by only the framework major connector and the rest seats, not the extension base. Then you remove the prosthesis from the mouth and measure the thickness of the alginate. If it's greater than 2 millimeters, a reline may be indicated. You have to definitely have a thin layer and a thinly mixed alginate. Otherwise, you won't be seating the prosthesis completely very easily. There are reasons to rebase or reline distal extension RPD, and they are: 1. The loss of tissue support, causing rotation and settling of the distal extension base. This causes increased torque forces to be applied to the abutment teeth by the direct retainers. It also causes a loss of occlusal contact between the opposing dentures or between opposing natural dentition and the denture. This translates into less efficient use of the prosthesis for mastication of food, and that doesn't make the patient happy.
A board question that was asked previously was, how do I tell if the patient needs a reline? The answer was, push on the anterior flange of the RPD and the distal extension lifts up. Push on the distal extension of the denture and the anterior segment lifts up. It may appear that the patient is still in occlusion when you have the patient bite down. That is not a determinant of whether or not it needs a reline, because as the partial settles, sometimes the tuberosities settle and it looks like the patient is still in occlusion. Chances are, though, the indirect retainers are up off of their rest seats.
The open mouth technique must be used when an extension base exists on the Kennedy Class 1 and 2. Because occlusion influences a rotation about the fulcrum, the chance of rotation must be eliminated when we make the reline impression on an extension base RPD. The framework must be held in its terminal position with the mouth open. We do not want the patient to occlude on the denture and cause it to rotate downward. The result would be that we would have the same outcome on the newly relined denture. The anterior rest and major connector would still lift up when you apply pressure on the extension base part of the partial. The reason it might rotate downward is that the teeth on the opposing arch or the complete denture itself may extrude downward as the partial on the mandible settles due to the resorption of the bone. This may result in the maintenance of occlusion, but the partial is still rotating about the fulcrum and stressing the abutment teeth. We must reestablish the lower prosthesis in its original terminal position with the rest and the major connector seated against the anterior teeth. Therefore, the open mouth technique must be used when an extension base RPD is what we're doing as a reline.
Some of the key points that need to be noted about relining a Kennedy Class 1 or a Kennedy Class 2 removable partial denture are these. It is not unusual for the patient to complain of looseness of a maxillary complete denture when it's actually the lower partial denture that needs to be relined. 2. It's the rotation around the fulcrum that is the determining factor of whether or not a patient needs the reline. You push on the front, the back lifts up. You push on the back, the front lifts up. If those conditions exist, then you need to have a reline. The framework has to be held in its terminal position during the impression for the reline. You cannot bite down on the distal extension part of that denture. So you have to hold that denture in place with the rest completely seated and the major connector up against the teeth for a proper reline impression to take place. Now, when you get that back, there's going to be a high probability that the occlusion in the posterior area on that extension base is going to be high, and you're going to have to adjust the occlusion. There are various types of removable partial dentures, and they respond differently to relining procedures. The all-acrylic removable partial denture, like the temporary denture, can easily be relined. Partial dentures with a metal framework in them are conducive to the reline procedure in the areas where there's base attachment and acrylic resin. The metal area of the framework cannot be relined. This would also apply to areas like facings, tube teeth, and metal teeth. The full metal base partial is ordinarily used only when a partial is made over tissues that have been accustomed to supporting previous denture base. In other words, no recent extractions. It is often used in an area where there is inadequate clearance for occlusion because there's not enough room for base attachment with acrylic beneath it and teeth on top of it. The metal base partial is not conducive to relining.
The following may answer some of the questions of when do I reline and when do I rebase. For a reline to be successful, the denture base must extend to cover the retromolar pad and the denture-bearing area and extend into the retromylohyoid fossa. The material will not flow into these areas without a base that supports the impression material. Bore molding compound can be used to extend the base a short distance, but if more than 4 or 5 millimeters of base is missing, an impression over the RPD must be made and a cast poured. The base will then be extended with repair acrylic prior to making your reline impression. A request for a rebase will then be made so that all the base becomes new acrylic on the denture. If you just reline this, then that repair acrylic will remain and the reline will just be below it. If you have excessive space between the arches due to resorption and/or occlusal wear, it may require placement of new teeth. Then a rebase procedure is indicated. Excessive wear of the teeth requires new teeth to be placed on the partial and a new processing. Therefore, that rebase is indicated. It's used also when the base is fractured on the existing partial. When deciding whether to do the chairside or the processed reline, you have to weigh the advantages and disadvantages of the chairside reline. First of all, the expense is less. With the chairside reline, all you have is the material that you're using along with your time, but the time is involved in both procedures. So that is one advantage. Secondly, the patient does not have to do without his denture. This is what the patient really loves. They walk in the door, they get the chairside reline procedure done, they walk out the door with their denture. They don't have to worry about being seen by a coworker or their spouse without a denture in the mouth. and they really like this. There is less time involved with that chairside reline, from a chairside time as well as number of appointments. There's also a decreased possibility of opening vertical dimension. When you send a prosthesis away to have a laboratory procedure performed, there is a chance that you're going to have an occlusal adjustment because there will be some processing errors that are incorporated into the procedure. It's kind of unavoidable. Also, there's little possibility of distortion of that framework. You don't have to worry as much about an older framework going through the processing procedure, and the possibility of something breaking is less on that chairside reline. The disadvantages, though, that material is more porous. The chairside reline will be rougher to the tissues than the hard acrylic processed denture. Secondly, the risk of getting that prosthesis locked in is greater with the chairside reline. You have to be very, very careful. It's sort of like you have with a temporary crown. You have to put that denture in place with the material in the prosthesis and take it out and in and out and in until that material goes through its hard set so that it does not get locked into an undercut. If it gets locked into the undercut, you'll be cutting that prosthesis off. Next disadvantage is color instability. The processed reline material will not stain like the chairside reline material. Over time, that chairside reline material will turn a brownish pink color, whereas the processed material does not change. The bonding of the material to the denture base is less stable with the chairside reline. Sometimes over time, that material will break loose from the undersurface of the base, and then your surface will be hard and rough and may cause more tissue irritation. Next, it stains much more easily the chairside material than with the processed reline material. Coffee drinkers and tea drinkers are going to find that there will be staining that sticks to that chairside reline more readily than to the processed reline. Also, if you have to extend the base, you can't really do that with a chairside reline very easily. It'll extend a little bit, but you're not going to get major change in those base dimensions with the chairside reline.
3 examples of chairside reline materials are being mentioned. The first is Permasoft, which is a soft denture liner, and it is one we use over in faculty practice. It's similar to your CoSoft used for tissue conditioning, but it has a longer period where the material remains soft. That's what gives it more the title of permanent. The GC Reline material shown here is a silicone material, which is considered a permanent soft liner also. It is quite expensive, though, costing about $45 per arch per attempt. The hard material that we have available for relines is a company called Tukusa who puts this out, and it is available from my office upon request. It must be used with close faculty supervision, as a mistake may result in that partial denture being cut out of the mouth. We don't keep it in the clinics for that reason. Before you rebase or reline any denture, partial or complete, it's absolutely necessary for you to get the tissues back to a state of health. Adjust the denture in any area where a lesion is present and allow it to heal before taking an impression for the reline or the rebase. Sometimes tissue conditioning may be necessary if the denture base is ill-fitting. Before any tissue conditioning material is added, though, any pressure spot must be relieved or you will not achieve your goal of a lesion-free area. The patient can also remove the denture for a period of time, but this is not always possible for the patient who works and does not want to be seen by their spouse with the denture out. Also, during that time, warm saltwater rinses are helpful during this healing phase.
Before you begin, obtain an RPD step card for relines that is available in the clinics and get each step checked off as you proceed. It's a double-sided form with repairs on one side and relines on the other.
We're going to go over the steps in relining a distal extension removable partial denture. First, we want to bring the patient back to a state of oral health. We're going to do that by, first of all, removing any area of the denture that's causing a denture sore spot. Then we're going to evaluate the need for tissue conditioning and do it if that's indicated. 3, we're going to ask the patient to remove the denture from his mouth until healing is achieved. This is not always possible, and that's one of the reasons we consider tissue conditioning. Before you even begin the reline, be sure to evaluate the partial denture needing the reline. Evaluate the extensions of the denture. Can you actually cover the retromolar pad and extend into the retromylohyoid fossa? If the current denture has very short flanges, can they be extended through the use of border molding and taking your impression in order to achieve a good removable partial denture? Can you achieve these results with a laboratory or a chairside reline? Answer these questions before you proceed to the actual reline or rebase procedure. The first thing that you want to do to proceed with your reline is to remove any undercuts that are present on the extension base area. You're going to be pouring an impression in here, but the person doing the reline has to be able to remove the partial denture from the cast that's actually poured. He cannot do that if there are undercuts that lock that denture base onto the pour-up. So remove all the undercuts. Another thing that you're really trying to do also is to provide a room for the impression material inside of that denture base area. If you're going to do a chairside reline, another thing that's important is that you remove that material because you want to provide a new fresh surface for the bonding of the acrylic resin material to the denture base. If you're not doing a chairside reline, then it's not necessary to remove material for that purpose. If you're doing a chairside reline, I like to add a little monomer to the undersurface of the denture base because I think I get a better bonding of that acrylic resin to that base when I just sort of clean the surface with a layer of monomer. If you have a specific type of reline material, some of them have an adhesive agent that has to be added to the surface before you go on with your reline. So make sure you know what material you're using and know what the directions are for that material before you begin. If your ridges have shrunk and you put in that denture and it's going down all the way to the base of the vestibule and digging into the tissues, you need to remove and adjust that flange to where you provide about a 2 or 3 millimeter space from the depth of the vestibule. That space will accommodate the new border molding that you're going to be doing at a later time. If you have an anterior edentulous area, then you also need to remove that flange 2 millimeters from the depth of the vestibule. When you do a reline, you have to reline all of the tooth replacement areas when doing that reline. You don't just do the posterior or you don't do the anterior if you think it's still satisfactory. While you're doing the reline, do every area where you have some type of prosthetic teeth in that area. Make a check of all your flange areas and see that you have a 2 millimeter space beneath the flange to the depth of the vestibule. Note on this one that we really have inadequate relief of the flange in that distal buccal portion of the mandibular. So go ahead and relieve it and then start your border molding. You must be able to do an adjustment of the occlusion after your reline takes place. At the time of the reline, it may be slightly out of occlusion and that usually is corrected with the Reline. But if there's excessive space between the two arches, then instead of a Reline, you may have to do a rebase and actually replace all of the teeth in that posterior area at the same time. So evaluate the occlusion for the feasibility to reline or to rebase the denture. You're now ready to border mold all of the edentulous areas. You do it much in the same manner that you do for complete dentures. You add the border molding compound, and then, for instance, in the anterior, you would pull out and up slightly, and at the same time massage the outer area of the chin or the lip to keep the border molding from being extremely thick. In preparing to take your master impression, be sure to practice the finger position once. The proper finger position is to place the fingers on the rest seats, to utilize any major connector that's up against those anterior teeth, but you do not want to push on the distal extension portions of the dentures during the actual impression making. In the posterior border molding, you're going to try and cover the retromolar pad if it's not covered by the existing flange, and also extend into the retromylohyoid fossa. It's always important to reestablish the length of the flange for proper coverage and proper support during function of the denture. This slide just reminds you of the proper finger position while you're taking the impression, and the fact it warns you not to push on the extension bases during that impression making. The impression can be made with various impression materials. In our clinic, we usually do it with polysulfide or polyvinyl siloxane. Other materials like polyether and zinc oxide eugenol are very, very good impression materials. If you do polysulfide, you need to pour up that impression as it will distort more rapidly. While you're taking that final impression for the Reline, make sure that you border mold the borders of the denture while the impression material is coming to a final set for best results as far as length of flange. When you can use a fingernail and not leave a dent in your impression material, when it pops right back out at you, you're ready to remove your impression. Make sure that the internal portions of your impression are nice and detailed and accurate. Polysulfide does a better job at this than polyvinyl siloxane. You should also adequately be covering your retromolar pad and extending into your retromylohyoid fossa. If you have all of these details, then you're ready to proceed. With a Bard Parker blade in one of those red-handled lab knives, be sure to trim the impression material back to the finish lines before you send it off or pour it up.
You will need to rebase this partial denture if the base could not be extended far enough using border molding compound. You can only accurately border mold approximately 4 to 5 millimeters at most to be assured of a good success with your Reline. So after removing the impression material back to the finish lines, also remove any material from the posterior above the retromolar pad, which doesn't allow the arches to come together properly and doesn't allow your impression to reseat in the mouth. You then want to reseat the framework in the mouth and make an overimpression with alginate on top of that impression. That way, then you will pour the cast up with quickstone, and you will capture those missing areas of anatomy with this impression, with this double impression. Another rebase is indicated when you wish to change the teeth to either close the occlusion because it's open or improve occlusion where you have really worn teeth and you want some new tooth surfaces. But you have to do the following steps in addition to where we left off. After removing the impression material back to the finish lines, you'd also remove any material in the posterior that interferes with allowing the jaws to close into occlusion. You would reseat that framework with the impression in it, make sure that it's completely seated into the rest seats and that the major connector's up against the teeth. Then you want to record a centric jaw relation record with a removable material like a polyvinyl siloxane, an example being Regisil, or something like Blue Moose. Remove that from the mouth and also make a face bow registration. Then make an overimpression of that arch with the Reline in it with alginate material. You would remove the alginate impression and hopefully that framework will come with it that has the Reline in it. Then pour your cast in Quickstone and then use your centric jaw relation record and face bow to mount the case on an articulator to send to the laboratory. When you have your case mounted, if that's necessary, when you have all of your materials together, when you have your signatures on your step card and your prescription is ready to be written, you may obtain the blank from the dispensary window. Fill out the prescription and get all the signatures necessary from your faculty, and it will be turned in to the South Lab dispensary to go out to the laboratories. Sample prescriptions are in your RPD manual.
When the case comes back from the laboratory, you should make sure that you have scheduled the delivery of the Reline and then either a 24 or a 48-hour adjustment because the patient will get some sore spots. Also, having one about 4 days later, and then you will see that patient on 1-week intervals until you have the patient lesion free, at which time you can get credit for your Reline. The first thing you should look at when you try to deliver this removable partial denture is check to see if there's any flash acrylic up in the guide plane areas or up on the undersurface in the area of your abutment teeth. Also check to see how the acrylic is on that flange and make sure that it's not extended into the undercut on the distal of the abutment teeth because those two areas will prevent your denture from seating adequately. Next, use pressure indicator paste on the undersurface of the denture to remove any pressure spots. You should have good pressure evenly distributed along that area of the buccal shelf and not undue pressure on the lingual walls, which are covered with very thin mucosa. Lastly, you'll adjust the occlusion of the denture after all of the pressure spots have been removed. In what order do we proceed through the delivery of the RPD Reline? The first thing that we want to do is to relieve any flash that may appear up into the areas of the metal framework that prevent our denture from seating. Secondly, you're going to use pressure indicator paste to relieve any of the pressure spots on the denture flange areas. And then lastly, you will adjust the occlusion. D and E we do not do unless the occlusion is so far off that it makes it easier to adjust the occlusion on an articulator than in the mouth. As a general rule, any RPD over RPD or CD over RPD is adjusted in the mouth. Hopefully we have a happy patient when he leaves our practice.